everyone and we straight away go to the debate. Whatever I'm going to state is out of the context of debate. I'm not against any procedure, seriously. But well, ironically, it's true that I think I would go on the side of CABG. I want to ask you how many people know what is a successful angioplasty? A successful angioplasty is after which the residual luminal diameter is not, the residual stenosis is not more than 50%. So leaving a 50% lesion in a vessel is a successful angioplasty. After which there is no MI, patient does not need a bypass, and there is no abrupt vessel closure. He has mentioned type A lesion. Can you believe the success rate of a type A lesion is more than 85%? But if I tell you I'm going to do a bypass and there is a 15% risk of a bypass, how many would you send? How many of you would send that patient to me? No one will send that patient to me. So already there is a 15% even in a type A lesion, which is the best possible lesion. Good target, good vessel, good everything, and there is a 15% risk in angioplasty. And this is not me. This is ACC, AHA stating so. Coming to type B, there are 2 type B lesions for this patient. And for type B lesion, the success rate is moderate, 60 to 85%. So if I do a bypass surgery and I say there's a 40% chance of failure, are you going to send that patient to me? Yes or no? No, nobody's going to send it. I know that. And in that also there is type B1 and there is type B2. If it is B1, it is still okay. B2 is considered complex, very bad lesion with a very poor outcome with plasty. This is what is suggested. This is what a normal plaque looks like. Imagine pushing stents, wires, balloons, catheters, IVUS, everything into that. Now, what is this pathology? Coronary artery disease is atherosclerosis. And most of the myocardial infarction, I want to impress this point to all of you. Most of the MIs that we see are because of non-flow limiting lesions rupturing and causing acute myocardial infarction. Second, coronary artery disease progresses from proximal to distal part of a vessel over time. And the vast burden of plaque is only in the first few centimeters of the artery. This is a paper I want all of you to read sometime in your life. And it is written that majority of the infarcts are generated by non-flow limiting lesion. But PCI is slowly focused only on treating flow limiting lesions. Thus, PCI cannot be expected to significantly limit new infarcts. But CABG may do so through providing flow to flow to vessels distal to the occlusions. Not only that, it bypasses all the plaques too. So if this is the PCI, like this is a PCI, there may be plaques above and below the PCI. But CABG will be beyond all the plaques. The graft is distal. And I will show that point again and again to you. This is a study that shows that most of the infarcts are because of vessels that have less than 50% stenosis. Imagine plastic, after plastic, you have less than 50% lesion left after a plastic. And most of the MIs are because of less than 50% lesions. So imagine what is the chance of MI after angioplasty. If there is a plaque in the proximal artery, that is 50%. That can still lead to myocardial infarction. And most of the times 50%, this looks 50%, this is not significant, let's leave it alone. We'll treat the critical part. That's how the cardiologists go. So both these techniques treat coronary artery disease, but myocardial infarction is common after PCI and not common after CABG because the graft in CABG goes beyond the entire plaque burden in the artery. And that is why, like I've written, the majority of bypass grafts are placed distal to the potential vessel occlusion from CAD. Hence, coronary bypass prevents against infarction by covering anodoid zones at risk for ST segment elevation MI, which does not happen with PCI. What does the data say? All of you have been talking about mortality, mortality, mortality. So let's look at morbidity and mortality. This is a meta-analysis by Sipahi et al., which included most of the major trials. And what did it say? It favors for myocardial infarction, less incidence CABG. Look at repeat revascularization, it is in favor of CABG. Look at MACE events, favor of CABG. Only where PCI is favored is in event of stroke. Look at this. What does CABG do? There is a 27% reduction in long-term all-cause mortality and a 42% reduction in MI compared to PCI. 42%. Can you beat that percentage? 42% in MI. And we want a PCI for a patient 35 years old? I wouldn't do that. These benefits of CABG are so meaningful that we should prefer CABG over PCI. Look at this. He has mentioned all these A, B, C, D lesion. And this is the ACCHA 2022 paper, which says in all the data put together, if you try to do angioplasty in a complex lesion, B2 and B1 are nearly complex lesion, then the mortality is bad and the 5-year outcome is worse if you do PCI. Clearly it is worse. This is what it is. Look, 6.8% for single vessel and 9. ABC lesion. So it's A lesion, you have 6.8% failure at 5 years. If it's a B type lesion, 9.9, and if it is a B2 type lesion, 11% failure at 5 years. And this is for single vessel disease. By ACCHA, you got failure of stent. This is for single vessel. Imagine you put 3 stents, where would the failure be? 30%? Imagine where your patient is headed to. And look at this. They have reported death at 5 years. Look at the death, 8.2% death. And target vessel failure, 14.8%. Means if you do PCI, 8% patient will be dead at 5 years. Do you want death? We don't want death. We want patient to live. See, PCI only relieves symptoms. It does not prevent death and repeat MI. What is the failure rate? It's mentioned here. Long-term stent thrombosis rates were increased in complex lesions despite use of second-generation DES. Use any type of DES, it doesn't work. Look at this patient, this paper, coronary artery bypass surgery, recent paper, 2016. What is the survival? Despite aggressive nature of coronary artery disease in young patients, even in young patients, the perioperative morbidity death is very good. What are the survival rates? 5, 10, and 20 years, 98%, 95%, 79 or 80%. Look at that. And freedom from complications, just look, 97, 91, 65. What excellent long-term outcome. If you do good arterial grafts, survival is done. This was an everlimous trial. Look at the data. This is the total death, myocardial infarction, repeat stroke on this side. Look at this. Where is CABG? 14%. Where is PCI? 21%. And composite endpoints are also different. All of you keep EMPA, DAPA, REPA, you worry about mortality. Why don't you worry about PCI versus CABG? Look at it. Look where the data is. Send your patient for CABG. Don't let him die with a PCI that kills him. Really, that's how it is. I'm not joking. I'm very serious about it right now. Look at this trial that was done through syntax and otherwise. And what is the outcome? Look at this. Multivessel disease, the green, multiple grafts if you are done. Where is the mortality for multivessel arterial grafting? And where is the mortality and outcome? The blue line is the multivessel stenting. You cannot compare this sort of data. You cannot compare PCI with CABG. I'm not trying to compare it also. I'm just trying to tell you, if your patient has triple vessel disease and you want him to live, it depends what you want him to do. If you want him to live, talk about CABG. This is what syntax says. You have a complex syntax score, the mortality in PCI goes up. But CABG, whatever the score, the outcome is good. Why? Because grafts are done distal to the atheroma, distal to the plaque, distal to the problems, distal to everything. Look at this. This is the number of papers, and this is just a small screenshot. I can give you 1,000 papers that give you the outcome of CABG. CABG means survival, live. The patient lives, he does not die. That is what. Now, suppose if you want to say, okay, what should an ideal graft or an ideal stent be? So I say stent should be done. An ideal bypass should not occlude. That is the most important thing. If it doesn't occlude, you can put it everywhere and everything is fine. Look, what is the quality of left internal mammary? It is a wonderful thing. It secretes prostaglandin I2, endothelial 1, tissue plasminogen, transforming growth factor B1. It is a capacity to secrete nitric oxide. You know, when you put a Lima 2 LED, you do arterial grafts like bilateral mammary onto a heart. It keeps secreting this nitric oxide, prostaglandin, and it prevents progression of disease distally. That is very important. Put a stent, and after 6 months, there's huge disease distally. That doesn't happen because these arteries, they secrete a lot of drugs, a lot of hormones that keep the coronaries dilated. Look at IMA. IMA has got a fenestrated internal lamina, and that prevents thrombosis. It is extremely excellent high velocity flows. Imagine the flow going through a mammary artery into the heart. Phenomenal. Whether he does effort, he's running, anything, nothing happens to the patient because it has a resistance to shear forces, everything you can imagine. They've written left internal mammary artery versus coronary stents, impact on downstream coronary stenosis and conduit patency. What happens distal to a mammary artery? It is written Lima grafting to left artery associated with significantly lower risk of downstream coronary conduit progression compared to percutaneous coronary intervention. So not only the graft flows, distally the LED also flows. Now compared to this, I want an ideal stent. Okay, what would an ideal stent be? It will be free of thrombosis, not require repeat vascularization. It will maintain vascular function. It will be wonderful. So what happens if we get a stent like this? We can plaque the whole first few centimeters of LED, first few centimeters of circ, first few centimeters of RCA. Just put a lot of stents everywhere, plaque everything irrespective of a lesion. you would have to stent everything is irrespective of lesion, not with the lesion or without lesion. Why? Because these plaques only rupture and cause coronary artery disease. And don't tell me I was for OCT. They hardly bother about plaques. I don't know how many people get an OCT. So cardiology has been coming up with these eureka moments. If you won the battle like this, first eureka, 1977, I've got balloon angioplasty, no more CABG. After a few years, oh, it didn't work. Then they come with the first generation BMS. Oh, it's very good. We will solve the problem of these stenosis. Again, thrombosis did not work. Then they came to first generation DES. Wonderful. It did not work. Next thing. Every time they study 5-10 years and realize they are wrong, you lose people. People die. You are again and again comparing it to CABG, but people die. Imagine these trials kill patients. They don't keep people alive. Remember that much. And again, they came with further beautiful stents. And now they have got eureka moments. Now we have got IVC, IVAS, OCT, this, that, everything. Lithotripsy, rotablation. Arre, what rota litha? You are killing people. No, really, I'm not joking. It's a fact, yeah. Imagine if you have got plaques, you have to come to my theater and see the plaques. Arre, they look like rocks. Imagine putting a stent and a rota and an IVAS and a litho into that and trying to crush that junk. And what happens to the epithelium? There's no endothelium left after that. It's garbage. And the disease as such is going to come there. It is going to come there. So I don't think yet cardiology has come to the eureka moment where they say, now we have won the battle against CABG. And why? It is not that they do a bad angioplasty. They do wonderful angioplasty. At the time of angioplasty, if you see the angio, everything looks wonderful. But why does the disease come? Remember, understand the disease process and you will understand why CABG does well. This is what I've drawn. Where does the disease come? Disease will come, progress everywhere proximally, all bifurcations and all the places. So if the disease is going to come everywhere proximally, what is going to happen? Imagine if they put a stent here. Sorry. Flow is there. That is where the atheroma, even in your house, the junctions are where the things get together. Just last piece there. And look at cardiac surgery. Eureka moment. Our eureka moment was 1964. A few days after my birth. I was born in 64. There, Kolosov did the first CABG Lima to LAD, and still that Lima to LAD is our eureka moment. 50, 60 years on, 58 years on, cardiac surgery has not changed. It is mentioned. The magic of left internal mammary artery graft. And look at this, 96.4% patency and survival rate. So it is the impact of collateralization. CABG gives relief of symptoms, prevents MI, reduces mortality. PCI gives only relief of symptoms, and that also temporarily because the plaques are going to rupture and give it. And that is what collateralization, I just said, that is why it prolongs life. No other reason to prolong life. Imagine all these papers are there without improper lipid. Just now someone said improper diabetes. Still we look at a 20 and 30. I had a patient today, a few days ago, 91, the first CABG we did in civil hospital. That guy is now 92 years old. He came with his daughter. In 91 we did CABG. 32 years later, he's still alive. And now what is the life history of CABG? Let's look at economics. This 37 years old, he has a Bima, 3 lakh cost. 30 years later, maybe a redo CABG. He lives another 20 years. It's okay, 6 years, 6 lakh cost. Look at PCI. OCT will cost him 5 lakh. After that, a re-intervention 5 years. Then he gets an MI. He comes to us. We do a CABG and mitral repair with EICD. And then he lives in class 3, class 4. And he ends up spending 30 to 40 lakh. This is industry. Spend 30, 40 lakhs. Lovely. The hospital does a lot of work. And everybody has a lot of work to do. And everybody is starting DAPA, GLIPA, because patient is in heart failure with diabetes. And imagine if you've done CABG, this is where you are. So it's not about playing with toys like Rota, IVAS, Litho. It's about making the person live. We want him to live, not get there. Okay. So let our patient live. Let him age gracefully like good wine. Surgeons have Ma on their side, and once mother is on your side, nobody can defeat them. Thank you.
जाऊं उससे पहले I will first rebut what he said and what all he was showing. He showed you 2015 का डेटा फ्रॉम पार्क. 2015 का पार्क इट ऑल डेटा अपन दोबारा देख लेंगे साइड साइड आपका. 2015 का पार्क ऑल डेटा, उसमें भी कन्वीनियंटली ही मिसेस आउट ऑन द मिडिल पार्ट वेयर इट शोज दैट द CABG had higher curve than the middle. You want to show that slide? I'll show it to you. Again the rebuttal on the CABG, इधर डाला इधर डाला इधर डाला, इधर आएगा उधर आएगा, जहां मैं डालूंगा उधर कुछ नहीं आएगा. अगेन इज अ रॉन्ग थिंग. उस पे जो आप पॉइंट करने के लिए उधर गए, उसमें सबसे इंपॉर्टेंट मैसेज सबसे ऊपर था, आपकी हॉस्पिटल का नाम. एनीवे, सो उसमें भी कैथ लैब है और उसमें भी कार्डियोलॉजिस्ट है और दो हैं. अब ठीक है, वो उसकी बात नहीं करते. अनदर थिंग दैट आई वांट टू टॉक अबाउट, दैट ही टॉक्ड अबाउट 50% रेसिड्यूल है सक्सेसफुल. 1988 का डेफिनेशन 2023 में दिखा के लोगों को कंफ्यूज करके विदाउट रेफरेंस बात करके, Anil Bhaiya has confused you all to go for bypass right now because you all will develop atherosclerosis in future. You all should go to Epic, lie down on the CTOT table, sir, naya artery dal do. But problem I have is you are putting Lima, you are not putting new LED. Put me a new left anterior descending artery. जिस दिन आप किसी और का डोनर का लेके नया एलईडी डालने आओगे, उस दिन आपका प्रोबेबली लॉजिक विल होल्ड ट्रू. You cannot compare Lima with a native LED. You are also putting something into it. So before I jump and go and talk about what this is, every cardiologist will tell you कि क्या बात कर रहे हो सर, इसको बाईपास में 37-year-old का ऐसा लीजन होगा और आप उसको बोलोगे तू बाईपास करा ले. Focal lesions, that's the problem. Surgeon is waiting to look only at the LED. LED में लीजन निकलना चाहिए, बाकी किसी वेसल में निकले ना निकले, I'll get of CABG. So that's the point that I was trying to raise, that if you have a triple vessel disease which includes a focal lesion in all the vessels, and then why not a PCI, especially if it's a young chap. Now why I like this patient, you can already see my PTCY inside and he's already undergone a PCI, of course, and I am very confident why I will do it. So what will be medical headline? Dr. Anil Jain created a headline. Will this be a headline if a dog bites me? No, it will not be. This will be if he ends up, this one crazy man goes and bites a dog, that will become the headline. So all the headline that he created was when the dog was bitten by a man. He didn't talk about the normal thing. Let me give you 10 important reasons in next 10 minutes and 5 minutes for the rebuttal. Reason 1 is the guideline. Now he tell me guideline kaun likhta hai, cardiologist likhta hai. No. These guidelines are written by a joint committee which includes cardiothoracic surgeon. And what do they say? Triple vessel disease without diabetes, both are class 1A indication when the syntax score is 0 to 22. Now when you have a patient who's got triple vessel focal type A lesions, what is his syntax score? This is syntax trial. He already talked about it. Very small trial. And remember, what was syntax? First generation. Paclitaxel, nobody uses now. Even that stent in low syntax score was like MiG-27, Indian Air Force does not use anymore. Even then, हमारे MiG-27 से जाके we bombarded and crashed F-16. So that was the 1 year follow-up. You had composite endpoint. Results were driven more frequent by, even in long term, by frequent PCI for all comers. But what about stroke? He did not talk about it. वो पेशेंट आपका 30 साल जिंदा रहेगा लेकिन पलंग पे लेटा रहेगा, एक हाथ पैरालिसिस, उसकी माँ उसको खिला रही है, बाद में बेटा खिलाएगा, फिर बेटी खिलाएगी, बाद में परपोती खिलाएगी. ऐसा 30 साल जिंदा रह के क्या करना है? Stroke rates, look at that, 4 times higher stroke rate in CABG as compared to PCI. You have a choice. You want to be paralyzed and being fed by your kids, or you are willing to get a second angioplasty done after 5, 10 or 20 years. What about 3 to 5 year data for all comers? 5 years, no difference in death. So ये जो मर जाएगा, तू मर जाएगा, bypass करा ले नहीं तो मर जाएगा, doesn't happen. There is no difference. 10 years again, no difference in mortality. I'm talking about syntax trial where we've used first generation drug eluting. I'm not even talking about fourth generation, polymer free, abluminal coating, ultra thin strut, no joints, side branch access. I'm not even talking about that. I'm talking on your front only. Low syntax score में क्या है? Syntax score is simple to calculate. Just put the values. Like in this patient, what is this syntax score? 12. 12 syntax score. You want to do a CABG? Why? Look at the data with taxes over 60 months. आपने 80 months का दिखाया and you scared us कि मर जाएगा. Look at that. There's no difference. No difference. Even clinical syntax score, which includes creatinine, LV function, peripheral disease, gender, bias, all included, even then syntax 2 would give you that you need either a CABG or a PCI. So now you talk about best trial. This is one of the trials surgeons never talk about. They don't want to talk about. Why? Because there was no difference in composite of anything in with the ever limb saluting stent. This is at the end of nearly 5 years. He's just 35. उसका बाईपास होने के बाद जब वो बाहर आता है वो 45 का वैसे ही लगता है, ऐसे पकड़ के चलता है, उसकी बीवी हाथ पकड़ के लेके जाती है और दिमाग से 55 का हो जाता है कि मेरी तो बाईपास हो गई, जिंदगी खत्म हो गई. He will come and ask the surgeon twice, can I ask you something in your chamber personally? अब उसकी बची क्या जिंदगी 35 की उम्र पे? What is left for him? What about new generation drug eluting stent? We have ultra thin strut, different platform. How do they fare? This is like 5th generation stealth air fighters. You know, we are not talking about 1st generation MiG fighters. There is no polymer. Taxus had a polymer. Problem with 1st generation was that there was some amount of polymer left behind, so no endothelialization. आप बता रहे थे इतना गंदा scary hyper microscopic view of a plaque and trying to scare us. That plaque is lost, completely replaced by healthy endothelium when you put a stent by neointimal endothelialization. आप लोग तो वो कचरा दिखाते हो पर निकालते तो हो ही नहीं, उसके ऊपर से नया डाइवर्जन. भैया यहाँ ट्रैफिक जाम है, तू बाहर हो जा, मैं उधर से लेके जाता हूं तेरे को. ये रास्ता बंद है, चल उधर से लेके जाता हूं तेरे को. मैं तो मेन हाईवे खोल रहा हूं भाई, सफाई कर रहा हूं और ऊपर से आपको दिखा रहा हूं बीच का रोड अच्छा है. फिर कहां प्रॉब्लम है? लीमा इज बेस्ट. अच्छा, पहले तो आप सर्जन आपस में डिस्कस कर लो कि लीमा करना है कि वेन ग्राफ्ट करना है. Because I know some of the surgeons, they say vein graft is best. Other problem is beating heart is best or on pump is best. अभी वो भी clear नहीं है. Then radial is best or vein graft is, वो भी clear नहीं है. अब I appreciate Dr. Jain. I mean, whatever he puts, I always tell this. Dr. Anil Jain is a fantastic surgeon. When he operates, if you get his patient with acute MI, उनका ग्राफ चल रहा होता है, दूसरी आर्टरी में ब्लॉक आता है. So he can argue कि दूसरी आर्टरी में क्योंकि मैंने ग्राफ नहीं लगाया था इसलिए बंद होता है. बट अगर आपकी थियोरी है कि एथेरोस्क्लेरोसिस है तो 2 लगाए थे, तीसरे लगा देते. क्यों नहीं लगाते? क्योंकि पता है उसमें वेन ग्राफ बंद हो जाता है, आर्टीरियल ग्राफ बंद हो जाता है, तीसरी आर्टरी बंद हो जाती है. सो दैट लॉजिक डजंट अप्लाई दैट यू आर क्योरिंग एथेरोस्क्लेरोसिस बिकॉज यू आर ऑल्सो नॉट ग्राफ्टिंग अ लीजन विच इज नॉट ऑप्टिमल. व्हाट अबाउट इंटरनल थोरेसिक आर्टरी? लुक एट दिस पेपर. 12 to 18 month angiographic follow-up, failure rate is 8.6% in this study. ये हमारे बेयर मेटल स्टेंट का थ्रोम्बोसिस रेट है. व्हाई? बिकॉज लीमा और बीमा का कोई बीमा नहीं है. बीमा या लीमा इज लाइक डिपेंडिंग ऑन द सर्जन, इट इज मेड इन चाइना. चल जाए तो आसमान तक, नहीं तो शाम तक. सो every lima, does it play for 20 years? No, it depends. Anil bhai is a fantastic surgeon, as I said. His graphs flow fantastically, but then he cannot tell all surgeons ki aap lima hi lagao. I know a lot of surgeons who do vein grafts and they flow very well. First ये decide करो beating करना है कि नहीं. आपने मेरे को बोला हमारा यूरेका मोमेंट आपका अभी तक नहीं आया, हमारा तो 5 बार आ गया, आपका एक बार भी नहीं आया. आप अभी तक कंफ्यूज हो वेन ग्राफ्ट के, आर्टरियल ग्राफ्ट, बीटिंग हार्ट के, नॉन बीटिंग हार्ट. रिसेंटली देयर इज अ पेपर व्हिच सेज on pump CABG is better than off pump CABG. Now surgeons are saying stroke rate कम होता है when you don't go on pump. I don't want to go on pump because if I not go on pump, we'll do an aortic bypass. Means we'll not touch the aorta, we'll not have any stroke. Still, stroke rates are more than angioplasty. What about AKI? Hazards were slightly more, but हमको डराते कॉन्ट्रास्ट दोगे वो किडनी खराब हो जाएगी. कॉन्ट्रास्ट दोगे किडनी. What is the incidence of AKI in CABG even when lima is grafted? More than 100% rise in mortality if the creatinine goes high, and at 3 months this persists. हमारा AKI in hospital होता है, आपका AKI permanent होता है, because that is not contrast induced, it is atheroembolic infarcts to the kidney. So when you handle the coronaries, you need to handle like a cardiologist, not like a surgeon. आपने दिखाया, मेरा भी वही फेवरेट एक्टर है. आज मेरे पास बंगला है, तो आज आपके पास टेंट है, आईवस है, आपके पास क्या है? तो हमारा पेशेंट एक्चुअली बोलता है मेरे पास मां कार्ड है. आपके तो आपकी मां लीमा, आपकी मां बीमा, बिना बीमा वाली बीमा जिसका आप बीमा नहीं करते हो, जिसका आप बोलते मैं मेडिक्लेम में ऑपरेट नहीं करूंगा, यू हैव टू पे कैश। हम गरीब कार्डियोलॉजिस्ट हम बोलते हैं माँ कौन सी, एक ही माँ, भारत प्रधानमंत्री वाली माँ, फ्री में करेंगे एंजियोप्लास्टी, दैट्स द कॉस्ट ऑफ स्टेंट। एंड लुक एट द गवर्नमेंट्स पर्सपेक्टिव, व्हेन यू डू 3 स्टेंट्स, the Ayushman Yojana packages, the amount that money government has to pay is also lesser than CABG. Surgeons have increased their bypass packages so much. Everybody gets IVP, on pump, off pump. Packages of CABG in Ayushman is now for more for CABG than for 3 stent angioplasty. और हम तो स्टेज करते तो हमको पैसा भी नहीं देते गवर्नमेंट. We do one and then you do second time, no extra charges. What is the important reason is how long will the patient stay? 24 hours, 48 hours. What about CABG? You've done NICAS, whatever. Triple vessel with वैसे भी नहीं होगा. Still 5 days. What about pain, scar, anesthesia? That's important. You tell the patient. That's important. This is how we do. वो tube डालेंगे. And so I have to very scare. When multivessel says, I explain it to properly to my patients. And then my surgeons came. आपने ऐसे बोला, डरा दिया. मैंने कहा डरा क्या दिया? I tell them, what is bypass surgery? I tell them, आपको बेहोश करेंगे, सीसी सुंगाएंगे, ट्यूब डालेंगे, छाती चीर के, फिर ऑपरेशन करके, टाके लेके, बंद करके, अगले दिन से वेंटिलेटर निकाल के 7 दिन पे छुट्टी देंगे. मैंने गलत क्या बोला इसमें? Is anything wrong in this? And you will take 1 month for that scar to heal. Am I incorrect? Am I incorrect? And I do tell them that maybe you will require a repeat revascularization, which is slightly higher than a bypass. Are you willing to get a second angioplasty done in 6 months, 1 year, 3 years, 5 years? He is 35-year-old. Yes, sir, I'll get a second bypass done. But I don't want that. I'm very happy with the surgeon, but I'm not sure about the anesthetist putting the tube in my one. Regroup trial, new DAS, which means better technique. But in CABG is still the same. 3 years, no difference in the rate of composite outcomes that included mortality, repeat revasc for patients who underwent endoscopic vein graft. आजकल मिकास, रोबोट, मिनिमल इन्वेजिव, की होल, नो डिफरेंस, नो डिफरेंस. दैट्स ऑल मार्केटिंग गिमिक, एज दे से. आपका नया स्टेंट, पुराना स्टेंट, हम बता देंगे आपको 3rd जनरेशन वर्सेस 1st जनरेशन, व्हाट इज द डिफरेंस. बट फॉर CABG देयर इज नो डिफरेंस. यू डू की होल, एक्चुअली इट मे बी बर्स्ट. बट वर्स्ट, मोस्ट इंपॉर्टेंट, आपके पास माँ है, हमारे पास बाप है. बाप इज कॉल्ड इमेजिंग. इमेजिंग, हम अंदर से आर्टरी देखते हैं. आपने कब आपने अंदर से आर्टरी देखी? आपने खोला, जहां पे ठीक लगा, एंजियोग्राफी में देखा, ये 2 के बीच में पाल्पेट करो, ऐसे पाल्पेट करो ग्राफ्ट को, लीमा को, एलईडी को. अच्छा, यहां पे सॉफ्ट है, खोला, वहां पे लगा दिया. दैट्स हाउ यू पुट. वी गो इनसाइड द कोरोनरी, सी हाउ इट इज, वेयर द प्लाक बिगिंस, वेयर द प्लाक एंड्स, एंड वी स्टेंट एवरीथिंग. Dr. Jain, we stent everything from 0 to 0 and take a longer stent, and we don't leave any plaque behind. Because in FAME 3 also it has been shown that the bleeding, arrhythmia, kidney injury, rehospitalization, and I had thought Dr. Jain would talk about FAME 3, all were higher in CABG. I don't want to bleed, I don't want to die of stroke, I don't want to have a residual paralysis. I am okay if I'll get a repeat PCI. The drawbacks of FAME 3, if he would have talked about, he would have said, देखो FAME 3 में भी हम तो superior आए. Who wrote FAME 3? What was the controversy around it? But the drawbacks of FAME 3, in the FAME 3 written by a surgeon, the paper is imaging was used only in 20%. Completeness of revascularization is not analyzed. Women and person of color were not analyzed. What about it's only 1 year data? What happens beyond? You just wait and see. We also can do physiology. We have the most important concern, the social and morbidity concern. Some patients remain fearful for surgery. Just explaining the truth, as I say, most of our patients will say, sir, angioplasty कर दो, ठीक हो जाएगा ना. We anesthesia नहीं चाहिए, छाती नहीं चीरना है. And stroke, all said and done, all techniques spoken about remains high as compared to PCI. So this is how we ended up finishing this case fantastically with 3 stents. Patient is, so why you want to hunt the mountain for a small mole? Why do you have to dig out whole of the chest, dissect his lima, dissect his bima, and then वो बाकी टाइम बोलता रहता है, सर मेरे को पेक्टोरल पेन है. आप बोलते नहीं नहीं, वो तो लीमा का फ्लो डाइवर्ट अंदर हो गया. वो बोलता है सर पहले एंजाइना नहीं होता, एंजाइना होता था 15 मिनट में ठीक हो जाता था, अब ये 24 घंटा भारी रहता है दोनों चेस्ट. क्यों? क्योंकि आपने पेक्टोरल का फ्लो कोरोनरी को दे दिया, जिसके कोलैटरल नहीं है. थैंक यू वेरी मच.